Hello everyone, welcome to another lecture, and today we'll discuss something about basics of cerebral palsy. Cerebral palsy in itself is a very huge topic, so it cannot be possible to teach cerebral palsy in a small time period, but we'll just take the basics of cerebral palsy to make sure that you at least know and you have some concept about what the disease is about. And before we begin, I would like to request you to please like, share and subscribe and share it with your friends whom it might be useful to. So cerebral palsy. So what is cerebral palsy? It is a group of permanent disorders of movement and posture due to non-progressive or static disturbance. So let's break this down one by one. So firstly, cerebral palsy is a permanent disorder. Many of people come to you, many of parents of children with cerebral palsy will come to you and they'll say that, okay, we have read on the internet that stem cell transplant is a very good treatment choice for cerebral palsy. So the first thing that I would like to say that many neurologists and even me, we have I am clubbing all the pediatricians too in this. So no patient that we have seen has yet improved from stem cell therapy, and we do not routinely recommend it to the patient. So first thing is that it is a permanent disorder of movement and posture. So under no circumstances the child will get to normal. As you know, there are only three cell lines in the body which do not regenerate: the neurons, the cardiac cells, and the skeletal muscles. So these three cell lines never, they never post embryonic period or post neonatal period, they do not multiply. So once there is an injury, it stays permanently or it heals by fibrosis. So this is a group of permanent disorder, and it is a non-progressive. It is due to a non-progressive disturbance. So usually it is static in nature. The insult is static in nature. The insult is either hypoglycemic injury or it is hypoxic ischemic encephalopathy due to perinatal asphyxia during the neonatal period. So the disturbance that caused this thing to occur is, it is in the past and it is not continuing. So if it is continuing, like if you have a patient of, any inborn errors of metabolism or mitochondrial disease, so these are progressive conditions. So they might usually be, confused with cerebral palsy and all the leukodystrophies that you see, adrenoleukodystrophy, metachromatic. So they might present as cerebral palsy, but they do not have the history of the insult at birth and they are progressive. So this is the thing. Now the child may fail to, they may fail to show some developmental signs, or there might be developmental delay, but the insult is not progressive. What I'm telling you is that the insult that occurs inside the brain, or the MRI that you did at the age of 1 month, the MRI will stay the same. The brain picture will not change. The clinical features may change later on, because again, that as the child grows, many of the defects get uncovered. So that might happen, but the insult is one time, it is static, and it has occurred during the neonatal period. So no matter what you do, it will not be the same. So this is the first thing. Now there is, these motor disturbances are associated with disturbed sensation, disturbed perception, there is abnormal cognition, there is abnormal communication and abnormal behavior. So all this is present. So we'll go into the etiology. So etiology, as you know, the most common etiology is hypoxic ischemic encephalopathy. It occurs in the neonatal period, and it occurs due to perinatal asphyxia. And as you know, there are the Sarnat and Sarnat stage for the hypoxic ischemic encephalopathy. It might be due to intraventricular hemorrhage that occurs into the preterm, and the classification that you may use in IVH is Papil classification. Okay, so this is the other cause. The third cause might be that, there might be meningitis or an insult. Meningitis or an infection that, caused the impairment of the blood flow. It might be hypoglycemia, or it might be anoxic episode. It might be anoxic damage post convulsion. So this might occur. So all these are causes of the perinatal or the cerebral palsy that occurs in the later period. Now, what happens is that there are grossly it is divided into 4 or 5 categories. The cerebral palsy is divided into 4 or 5 categories. So the first category, as you all know, is hemiplegic CP. Hemiplegic CP. So what happens is there is history of handedness. Now usually this handedness or the left-handedness or the right-handedness occurs normally. It occurs around the age of 3 to 4 years. 3 to 4 years. Now, if this handedness occurs less than 9 months, if this handedness normally occurs in 3 to 4 years, but if this occurs less than 9 months, it is definitely pathological. Definitely pathological, and so you have to investigate further. So this is what happens is there is a handedness, there is early hand preference. Early hand preference, as you all know, that children initially are bidextrous and later they become unidextrous, like we have an hand preference. So this is what occurs in the newborn period. Now what happens is there is a circumduction gait. Circumduction gait. What is circumduction gait? One leg is here, other leg is here. So child will walk like this and the other leg would come like this. Then the toes go well, the one leg would go, then the other would come like this. Do this like this. So this is the circumduction gait. Circumduction gait. And the pathology or the damage is the contralateral parietal lobe. So here is where the damage, you will find this damage. Now in this condition there is maximum involvement of anti-gravity muscles. So anti-gravity muscles, the hip muscles. So there is tiptoe movement, like the patients that have Duchenne's muscular dystrophy, they also have a tiptoe movement. So the circumduction gait along with the tiptoe movement, and around 1/3 of the patients have seizures, and 1/4 of the patient are mentally retarded. So this is one of the less severe forms of cerebral palsy, and here we have 3/4 patient with normal IQ or falling within the normal age. So this is the first type of CP, and it occurs either due to perinatal stroke, and it is due to the damage to the contralateral parietal lobe. The one side of the body is involved. So that is hemiplegic CP. The next one is diplegic CP. So what happens in diplegic CP is there is spasticity. Now this is spasticity is clasp knife spasticity, and this spasticity, the spasticity you see is more in legs compared to the arms. So the lower limb is more involved than upper limb. Now why does it happen? This happens due to damage to the immature brain. Damage to the immature brain. So as you might have judged that this immature brain, the most common weeks are 20 to 24 weeks. So it is associated with preterm delivery and intraventricular hemorrhage. So this is what you see. Now what happens is that this patient has history of difficulty of wearing diapers. Difficulty of, the mother is telling that there is difficulty in putting on the diapers. Not the diapers, not the diapers that you close, the diapers that go around like shorts. So this new diapers that we get that go around the shorts, they like the shorts, there is a difficulty in wearing diapers because the child's legs are so stiff that the mother is unable to bend them to push the diaper up. So there is a history of wearing a diaper, and these children actually drag their legs around because the legs are spastic. They cannot see. When we walk, there is, flexion, extension, alternative movement. When the legs are spastic, you do not have that normal movement of the legs. So you have to drag your legs, and it acts like a rudder, So, the child, crawls like this, like a commando, and the leg, they are dragged behind the child. So like a commando, as you have seen in the movies, that there is a barbed wire and the commando goes below the barbed wire in the military training. So that is called as commando crawl. So they drag their legs, and their lower limb act as rudder, and the movement they have is called commando crawl. Commando crawl. So this is what happens. Then later on, the child is unable to sit, and later there is, disuse atrophy of the muscle. Long term, there is long term issue of cerebral palsy. There is, that there is, a lot of disuse atrophy. And when you do MRI, you see periventricular leukomalacia, periventricular white matter. There is a whitening. So leukomalacia. This is PVL. This is known, for short, it is known as PVL, periventricular leukomalacia. And there is, shrinkage in periventricular white matter, shrinkage in periventricular white matter, and there is enlargement of ventricles. So this is what you see in diplegic CP. Now this is more severe form of the hemiplegic CP, because here, all in all four limbs are involved, but the lower limbs are, grossly more involved compared to the upper limbs, and there is, some movement present in the upper limb. So, the child can, work basics. The child can catch a spoon or learn to eat by himself in this condition. But the third condition that we'll see is the worst, and it is spastic quadriplegic CP. As you can, make out from the name, that, all four limbs are very, very badly involved. This is the most severe and the worst, and there is, even associated with, bulbar and pseudobulbar palsy. So what happens is, in bulbar and pseudobulbar palsy, what happens is there is swallowing difficulty. Now you know the difference between bulbar and pseudobulbar palsy. Bulbar palsy is the involvement of the medulla, and pseudobulbar is the upper parts of the above the which might act as like a bulbar palsy. So this is the difference between bulbar and pseudo. So swallowing difficulty. Please mind my spelling. It is swallowing. It is not swelling. It is swallowing difficulty, and there is cranial nerve involvement is always present in quadriplegic CP. So cranial nerves are always involved. There is so much damage that cranial nerves are always more involved, and here upper limb are more involved. The spasticity is more in upper limb than lower limb. This is exactly opposite of the diplegic CP. Now again, when you do MRI, you may find PVL, severe periventricular leukomalacia. You might be finding, and there is, gross, all the four lobes are involved. All the four lobes are commonly involved. So this is what, the worst CP is all about. The fourth CP is athetoid CP. There is also fifth cerebral palsy, and that is atonic CP, and it is seen with cerebellar involvement. We'll see next. So athetoid CP is choreo. There are chorioathetoid moments. So extrapyramidal involvement is there here, and usually posterior putamen is the most common site. Bilaterally symmetrical involvement, and other common site involved is ventrolateral thalamus. And when this is called, it is also known as status. No, the brain is involved from all the place, then it might be called as status marmarotus. So what happens is that there are lots and lots of small areas that are involved in the brain, so it might lead to athetoid CP. And there is dystonia. As you know, dystonia is a hallmark feature when there is extrapyramidal involvement of basal ganglia. So dystonia is present, and there is an abnormal tone. Again, upper limb is more commonly involved than lower limb. And what are the causes? The most common cause again is perinatal asphyxia, but the more specific cause for this is kernicterus. So kernicterus may lead to this, and a condition that mimics athetoid chorioathetoid CP, Sagawa disease. Sagawa disease is a DOPA responsive dystonia. So when you have patient of athetoid CP, please give a trial of L-DOPA. It is a DOPA responsive dystonia, and these patients usually respond very well to L-DOPA. So this is what is all about. And the next, the MRI is the diagnosis of choice. But again, after doing an MRI, you do not get any clarity about the picture, that because see, that this cerebral palsy is a clinical diagnosis, and that the patient has cerebral palsy. So after you do MRI, you do not get any additional information, because there is again no treatment. And the only thing that you can do is explain the prognosis, that we'll go into the next slide. Now, initially we talked about the bulbar and pseudobulbar palsy. So bulbar palsy is abnormality in medulla, and pseudobulbar palsy is abnormal in corticobulbar tract. So it is above the medulla. So again, both have dysarthria, dysphagia, but the only difference is that mood and gag reflex. So this is LMN. So gag reflex is absent. This is UMN. So gag reflex is exaggerated or brisk. It is positive, but it is brisk. And the mood is here is normal, because again the upper parts are not involved, while here the mood is labile. So this is just a run through of pseudobulbar and bulbar palsy. Now, as you know, that MRI is the only thing that you can do, and if again, doing MRI has no additional benefit, and usually many pediatric neurologists or even pediatrician do not advise doing MRI, because it will just add to the cost. Now, for the treatment, the first thing is prevention. So therapeutic hypothermia has been successfully used to cool the brains down. 48 to 72 hours it is used, and the brain is cooled down to 33.5 degrees Celsius to sometimes 32.5 degrees Celsius. So this is cooled down for 72 hours, and then it is gradually rewarmed. Now what happens is it decreases the metabolism of the brain, so it limits the damage to the brain. Now therapeutic hypothermia in itself is a long lecture, so we'll not get into the detail, but therapeutic hypothermia has shown remarkable results in preventing the brain damage. And the treatment, or the treatment for, again, the cerebral palsy, there is no treatment, but there is prevention of complication is an important part. Now what happens is physiotherapy is a mainstay. All patients must undergo for physiotherapy, so they the spasticity does not progress to a limit that the limbs become wood, they become like wood. So what happens is you have to give physiotherapy to each and every patient, and it helps this patient to get rid of the contractures, which are very, very, very painful, and they help them to gain some functional abilities. Now again, you can use other treatments to prevent complication is that you can give intrathecal baclofen. So it decreases the spasticity and it penetrates the blood-brain barrier when you give inside the brain. You can give botulinum toxin. Again, botulinum toxin decreases spasticity. So you can give that. You can give dantrolene. You can give trihexyphenidyl. So this you can give. All this you can give. You can give benzodiazepine. So all this you can give, and the deep brain stimulation has been tried, and now many pediatric orthopedic and pediatric surgeon they help, they do tenotomy to prevent the contractures, prevention of contractures, and they help in functional rehabilitation of the patient. So that is a very important part practically in the patients of cerebral palsy. So I guess that is all for today, guys, and I hope you like the video. And if you like the video and learned something from it, please give it a thumbs up and share it with your friends, and I'll see you in the next one. Bye.